You are mine.
Hello. Hello? Okay. Okay, everyone. So we're going to start our first session now. It's a real privilege to be able to introduce our panel guests today. And I'm really, really excited to be able to hear their various discussions over the next 45 minutes. Portia will have a couple of live mics in the audience as well. But if we just flick onto our next slide, if possible, please, we will have our QR code again. Please use the QR code and ask questions. It'll go to Portia's laptop, and then we'll be able to ask them if you don't want to actually use the mic and do it yourself. So before I start, I'd really like to just introduce our panel, and each of our guests are going to do a couple of minutes to say who you are and what's your involvement in SMA. So Channa, if you'd like to start us off.
Thank you, Giles, and thank you, SMA UK, for inviting us today. So I'm Channa Hewamadduma. I'm an adult neurologist from Sheffield. So we look after patients in the middle of the surrounding region in South Yorkshire. So we started our SMA clinic way in 2005, but our patients were seen infrequently until the new therapies came up. Then we had to increase our game, and then we started providing a service for the whole region. And we are also part of the SMA UK reach, and we contribute to that. And then I also have the role of taking part in the NICE MAO Managed Access Oversight Group Advisory Board, as well as NHS England Clinical Panel. So I'm great to be here.
Thank you, Channa. And we'll hand over to Mariacristina.
Good morning, everyone. I'm Mariacristina Scoto. I'm a pediatric neurologist, and I work in London at Great Ormond Street Hospital. And I'm here because I see children with SMA in clinics, but my role I'm privileged because I can also do some research. I participate in clinical trials. So our site was one of the sites doing a trial in nusinersen, which was the first drug that was approved. I'm the principal investigator on our site of the SMA Reach UK. And actually, I'm the one who gave the name SMA Reach UK to what is currently SMA Reach UK. It was a SmartNet, and it was funded by the Jennifer Trust at that time. And so I'm here also because I work together with Channa. I advocate for treatments to be available in the clinic setting. And I know how clinical data, real-world data are really precious for us to push for treatments here.
Thank you. And then hand over to Lisa.
Hi everyone, so my name's Lisa Edel. I am a respiratory physio also at Great Ormond Street. I see all of our SMA patients in clinic, but I'm also very privileged that I get to split my time between seeing everyone in clinic but also doing research as well, and that's specific to respiratory care in SMA. I also recently get to sit on the SMA Reach Steering Committee, so involved in lots of different avenues within SMA.
Lovely. And then Natalie, our last guest.
Hi everybody, my name's Natalie Smith. I'm one of the neuromuscular nurse specialists at Great Ormond Street Hospital. I've worked with the SMA cohort there for around 8 to 10 years. Before treatment, I met my first patients with SMA in the intensive care environment. More recently, I've been able to get some funding to do some research looking at the lived experience of children and young people with SMA who are on treatment. And I'll be undertaking my initial research project this year. Other than that, I've been involved in setting up the majority of treatment services within our trust for all of our patients. And I think we have around 150 children with SMA on our service at the moment.
Fantastic. Thank you so much. So I want to come to Mariacristina first. We've obviously talked about the landscape changes so much over the last 40 years, from not even knowing about the condition itself to newborn screening. Mariacristina, from your side, when did you hear that treatment was an option for SMA, and what was that process from you from a clinician's perspective?
So I think we were all surprised when we embarked in the nusinersen initial trial, because none of us expected such results in the SMA type 1 group of patients. So I would say probably early 2017, we were really, really close to understand that there was a hope that a treatment could be available for our patients. And it took several months, Giles, from when the company Biogen at that time announced that they were able to offer the treatment for free in the early access program in 2017. And we actually started to treat our patient much later in 2018. And this is not because there was no goodwill or people really didn't want to treat patients, but because there was a service that didn't exist before. And while clinical trials are like an oasis where you have a lot of funding, very few patients, and a lot of people looking after these patients and treating these patients and looking after potential side effects, when you want to translate your experience from a clinical trial into the clinical setting, you have, I don't know, hundreds more patients, you have 10% of the workforce, and you have basically or virtually sometimes no funding to implement that. So it took quite a long time to set up a service, and it was not equal and nationwide. I think there was some diversity. There were some centers that were able to set up the service sooner and some centers later. And it was a very difficult time, and we went quite far long since then. And that was also an opportunity for us, and I think for the pediatric world to also communicate more with the adult network as well, because when from the early access program we moved to a managed access agreement, that I know can be a painful process, and we've been here for more than 5 years now. This gave us the opportunity as a network of colleagues and clinicians to set up some benchmark, to set some level of equity nationally, to say, okay, all of us, we need to provide this treatment. How can you improve that? And I think that was a good step forward to where we are now, where there is a strong collaboration between the pediatrics and the adult network, and there is a strong collaboration with the NICE and NHS England. I have to say, I don't know how many people will remember that at the beginning when the drug was approved, we could not treat non-ambulant SMA type 3 because there were no data from the clinical trial. This is another problem. Sometimes trials have a very restricted group of patients. And then in your clinical setting, you would like to offer treatment to many more patients, and you can't because there are no data. And what was, I think, unprecedented is that NICE and NHS England listened to us. It took some time, but they listened to us and listened to the fact that we wanted to treat patients outside the experience that we had in the clinical trials. And that was a very good step. And since then, I can say definitely that the communication, the understanding in the last 5-6 years has been much better. It's improved a lot in terms of the complexity of SMA and why we want to push for treatments.
Thank you. And Channa, I'm interested to hear your thoughts as well. There's a huge focus around the pediatric side of things, particularly for treatment in terms of early intervention. You're primarily working with adults as well. So I'd really like to hear your perspective of how much of a difference that's made to the adults, and then also how important the data collection part of that is to really the overall picture to make sure that therapies are consistent and rolled across all populations within SMA.
Thank you. I think building on what Mariacristina mentioned, around 2016, 2017, when you went to neuromuscular conferences, we did hear about nusinersen coming through clinical trials and early studies of gene therapy, but I never thought that this is going to be a game changer for adult SMA patients. However, in 2019, early part in July, when the NICE appraisal was going through, and they approved the drugs for adult patients, that was the pivotal point where adult teams had to think, well, this treatment is going to come to our clinics. We had 3 months to operationalize this. And so we had to come and take a stock what our services are like and how are we going to see our patients. Do we have a register of our patients? Fortunately, in Sheffield, we had a motor neuron disease and SMA, lower motor neuron disorder clinic. And so we had a few patients, and we realized that we need to take a stock of who's type 1, type 2, and type 3, etc. Because a lot of patients carried a very vague diagnosis of their type, but the treatment was designed for type specific. For example, nusinersen was only allowed for type 1, 2, and ambulant type 3, and then risdiplam came on, and it was initially applicable only for type 1 and 2. So that made us to reorganize our services. We had to ensure that our physiotherapy colleagues and we were ready to do the outcome measures that the NICE required. And this is where we organized ourselves as a network. So SMA Reach Adult Network was born with all our adult colleagues in the UK, led by Chiara in Newcastle, and then physiotherapy colleagues we all started working together with Robert Munilofra from Newcastle leading on the training for everyone. And that made us a strong network in order to bring these new therapies to adult clinics. And this was not without challenges. For example, when we went to managers and said, okay, this is early access to medicine scheme, treatment, can we access? They said, well, where's the funding? There was no funding to appoint new people. So we had to reorganize. When the nusinersen came, I had to go and find out who can do the lumbar punctures. And I begged and borrowed a nurse who could do the lumbar punctures. I said, okay, we only have 10 patients who are eligible with type 3 walkers. Let's start with that. And then now we have 36 plus patients. And initially we had only 24, but now we have 60 plus patients. And patients do travel from far and wide to access therapies. Now, we might forget that we've been through a COVID pandemic. And when the drug was available, nusinersen came in, it was July. It came to the clinics in December. We were the first to treat an adult patient in January and 2020, and then the COVID unfolded. And that put a significant challenge because the hospital said, well, you're not treating patients. We need to only focus on the emergency care. So we had to then put a paper to say that SMA patients are emergency. You cannot, time is motor neuron, time is muscle. So we need to get on with the therapies. It has not been that easy in order to support these patients with SMA patients with physiotherapy and ensure that they come regularly and then their nusinersen and risdiplam therapy is maintained without any delays. Now, answer to your question, what lessons we learn? I think SMA, I would say hats off to SMA UK and Treat SMA because I've been in the NICE panel when risdiplam was nearly not approved, but it's the patient's voice that I believe that got it through the line. So I sit in NICE panel for several other neuromuscular diseases where the drugs are not approved, and I could see the difference is patient voice. Most of the time. So patient voice has been fantastic in pushing the drugs through in SMA. However, I don't think the game is over. I think there is a lot more to happen, particularly the newborn screening and post-managed access agreement. What are we going to do with NHS England support? Is that there are challenges still waiting. I hope I answered your question.
And I think there's a couple of points that you mentioned in there, and I'd kind of like to bring in Natalie and Lisa as well about, we know that therapies are so effective, but there was a moment in time where actually to be able to deliver a service has been really, really challenging. And Natalie, from your side of things, I'd really like to understand like how challenging and how difficult and how much of a change there's been in terms of actually delivering that service to patients now that we have therapies.
I think you could start off by saying there was one SMA CNS at Great Ormond Street in 2016 for SMA, and there still is one, even though we're gaining patients. Channa touched on the pandemic. So we had a huge cohort of patients with type 2 and type 3 SMA to dose and start on nusinersen during the pandemic. And Mariacristina and Giovanni and I were taking calls at 9, 10 o'clock some nights because that patient had developed COVID. We didn't know whether or not they could stay in the patient hotel the night before. So that was a huge challenge in itself. And I kind of want to clap because actually looking back, we achieved that during a really difficult time. So
such a short period of time, from then
so
to
kind
now.
of like after we did that, I think it wasn't so difficult in a sense, especially to get going with risdiplam. We had to do a lot of extra clinics as a service and can make sure patients were consented and had the right information. And then we have again with other treatments such as gene therapy. We collaborate with other centres, so a lot of team working and a lot of extra time is needed from within the trust and within the professionals to get these services up and running. But once they're up and running, things, touch wood, go quite smoothly.
Well, good. And Lisa, from your side of things, obviously we have a huge new cohort with type 1s particularly. It's obviously the highest prevalence rate in the SMA world. We have 50 per year that are born and 60% of those are type 1s. Respiratory support is such a huge and vital part of that. We talk about the service delivery, we talk about the therapies. I mean, how much has the respiratory side of things changed and will continue to change over the next couple of years, especially looking back?
So I think the place to start is that even before treatments, the standards of care, especially for respiratory care, had changed in terms of ventilation and airway clearance. I think that moving forward from then to now, there's more patients, and as everyone has kind of alluded to, the services are struggling to keep up with. So when I started at Gosh around 10 years ago, I was employed to set up a respiratory service for our patients with neuromuscular disease. And I think when I went for my interview, they said, I think we've got about 20 patients. And that doesn't even cover our SMA1 cohort now. So I think we're up to about 300. So I think that the challenges are around being able to continue to provide that level of care that we all want to provide when the services are struggling to keep up. Now, I mean, we as a team strive to see all our patients whenever they need it. And we're very fortunate in that we have cough assist provision. We have everything that we need to be able, and we have a clinic every day, and we can provide that. But that is by no means equitable across the UK either. So I think that there are a lot of things that are still improving over time.
Absolutely. And we'll come into some of the other things that we mentioned about the network as well. So the network of clinicians within the UK is a very, very tight group. We are, I would definitely say, a world leader in terms of our expertise, our skills, our knowledge, and our experience. So, Mariacristina, it would be really great for you to just articulate what the SMA Reach Network do as well, and just how important that piece is to make sure that we continue to access therapies, but also connect that knowledge together and share all of that learning.
Yeah, so the SMA Reach stands for SMA Research and Clinical Hub. So our intention at the time was to boost a little bit the data collection. And what is interesting is that when we did that, our data collection was only on SMA type 2 and 3, because the pediatric neuromuscular service used to see SMA type 1 only once or twice maximum. And then they were followed by the palliative team. So we had to change completely the way we were looking at this group of patients. And we, exactly because we were in the position of knowing there was research coming, we said, okay, so we need to understand a little bit better what is happening to our population in UK. We need to understand if the treatments that are coming will make a difference. So this is why we kind of upgraded our data collection in order to include what we thought was relevant. And at that time, I have to say, we were kind of blinded because we went with the typical assessment that we were used to do in our clinical setting. And I think that SMA Reach created this network where not only consultants, physiotherapists, other health allies came into force to have discussion with what was relevant, what we needed to look for in order to follow these patients in the proper way. And the communication with the community and with the families, I think, became much stronger since the network grew, including more centers. What we do now, we do some service for NHS England, for NICE. We try to collect data on the effectiveness and the safety of all the 3 disease-modifying treatments that are currently approved. And this is because although there is emerging information about this treatment. The reality is that none of this treatment has been around for 20, 30 years. Things are relatively new, and we still don't know how these patients will be in 10 years' time, 15 years' time, what is the durability, how long the treatment will last. And apart from collecting data and trying to support what we see clinically, support the fact that we see benefits from these treatments, we're also looking into what else we should be doing, what other information are relevant for patients, for families, and what other information are relevant to modify or to have an impact in the way we treat patients and in the way the NHS England listen to us. Just to give you an example, we know that sometimes there are delays in providing gene therapy in SMA babies purely because the baby might not be well, or there might be some investigation needs to be done, and there is the referral to the treating center. And this creates a gap between when the child is diagnosed, which is, as we know, in this country is already late because they're diagnosed when they're symptomatic, and when they start the treatment. And there was no way for us to give a treatment before gene therapy. We have to stick with this pathway. And as a network, last year, we came up with some sort of guidance or recommendation that we all agreed that it was right and safe to give bridging treatment, especially when you expect your baby with SMA type 1 to wait another 2-3 weeks to receive gene therapy. And this was not something that was allowed under the NHS, but now has been endorsed. And there is this ability to do that now. So we, together with a network, with a consensus, with the doctors, physiotherapists, respiratory physicians, we all came with this consensus. And this consensus was endorsed. So we are now able and free to start bridging treatment, which without newborn screening is super relevant for us in order to avoid to have 1, 2, 3 weeks gaps before we can treat a patient. So we provide data, we communicate a lot with family and patients as an SMA Reach, but we also created a forum of great collaboration and communication, and this collaboration and communication has been able to change some policies. And hopefully we will be able to continue in this way. And there are many other things that we do in terms of training from a national point of view, organizing a workshop where we discuss topics that are relevant and things that are changing in order to be as much as possible anticipating problems and difficulties. I think later during the day, Giovanni and Anne-Marie will talk about how the care for these patients is changing and how it's continuously important to have this discussion as a network. There will be some posters about SMA Reach, so if you want to just look into that. But we couldn't do what we are doing if we didn't have a strong collaboration with the advocacy groups and the charities. So I hope that this will continue.
Lisa, I'm keen to hear as well. There are so many positives. You know, treatment has changed the landscape so well. From a respiratory side of things, what are the challenges that you're continuing to face on a daily basis, and also kind of looking forward ahead of what are those new challenges that are kind of in front of you?
I think from the respiratory side is that the children receive treatments and everything seems to be improving, especially from a motor point of view. And for whatever reason, the respiratory seems to be more delayed. So the improvement or decline in respiratory seems to be slightly different to that of motor. So a lot of the kids, even when they receive treatment, still require some form of respiratory support. And that is it changes the narrative quite a lot, because I always feel like the bad cop, because everyone else is really positive about how well their arms and legs are doing and how great head control is. And then I'm like, actually, our breathing's still not great. And there are other things that we need to look at. So I always feel a bit bad when those conversations need to be had. And I think it's the fact that there is still a huge respiratory involvement, because the kids are still being diagnosed once they're symptomatic. So I think that is a major part. And once we start to see symptoms, we don't seem to, at the moment, get full recovery of anything in terms of respiratory. So we are still very much requiring airway clearance techniques and ventilation and sleep studies, and the impact of the respiratory side of things has a massive impact on quality of life and kind of how these kids are going to do in the future.
And some of the other challenges as well, we talk about earlier we mentioned around about the kind of wave of new people that are coming through the system, and I don't think the system is prepared or ready for that transition period. I mean, Natalie, I'm keen
sorry,
to...
Giles, just picking up on what you were just saying there, like we struggle at the moment to transition some of our patients because of availability of equipment. So I've still got a 21-year-old patient because there isn't adult provision for patients who need cough assist, who have more complex respiratory needs. So I think that is going to be a massive area that we need to improve on going forward in the future.
Absolutely. And Nat, I'm keen to hear your thoughts in terms, we talked a little bit earlier about that kind of that staffing resource as well, way back when, there was, a few of you, basically the people in the room, essentially being able to do that. I mean, how much of a challenge is that going to be moving forward with having the right people there to be able to support what the future does look like?
I think that the right people are there in the tertiary centres, but the bigger issue for the SMA community now arises in the local community settings and equity of access to school, work, in the adult and child sector, access to care hours. I know some people who have 24-hour care packages, and yet there might be a family with a type 1 baby who's very weak and they can't really get access to much more than 6 to 12 hours. So we've also set up recently a nurses network to try and scope out what the neuromuscular care is like across England, Scotland and Ireland. And all I can say right now at this moment is it is vastly, vastly different. So if we're looking at standardisation of care and implementing care standards, how can we do that nationally when every centre is so differently funded? At Great Ormond Street, we don't have an OT. We just don't have funding for that. Now, there might be some people in here that think that's absolutely crazy. And a lot of what I do as a CNS is help families fight things from an OT perspective locally in terms of education, healthcare planning, mobility assessments and housing needs. So I think that's where our biggest challenge is. It's not so much the tertiary network, but it is, like you said, it's spreading the awareness, because we've got a cohort of young children and young adults who have very complex care needs, as Lisa said, who might look quite well, but things are actually different underneath it all, and they need that support in the community, and I just don't think it's there at the moment.
Yeah, absolutely. So, Channa, I'm keen to hear your words on this as well. So I know we're going to talk later. Anne-Marie's going to lead a session around our SMA care project. Natalie, you touched on that kind of inequity across the UK, and it might not even be from Sheffield to London. It might even be between London sites. It might even be between Sheffield and Leeds, etc. Channa, I mean, how important do you think it is now that we have that highest level of standard of care that is rolled out across the UK, and what difference that will make to families to be able to see what the gold standard is and be able to come to clinicians and the neuromuscular centres and local centres and say, this is what I think SMA should look like?
I think we have come a long way from how it was in 2019, 2020, but I think the journey is still long. The new therapies in SMA have given us a gold standard compared to what it was. Anne-Marie and colleagues are generating the SMA Care UK standards, and that was definitely set a benchmark that we can aim, and then on that we could build on as time goes on to help patients access therapy closer to their home. For example, if I look at my cohort, we have significant number of patients who travel long distances to come to our centre to access therapies, because we don't turn anyone down when they come. But I think it's unfair that they cannot access therapies closer to their home, and we need to address this inequity. I suppose the other challenge that we will face, in addition to ensuring that our patients with SMA have sufficient services to access when they transition to adult services, there are a number of other neuromuscular disorders are having new therapies come down their pipeline. And all these therapies might be hitting the clinics in the next 5 years or so. So we will be challenged. So we need to prepare as a network of neuromuscular physicians, therapists, and allied health professionals to prepare our ground ready. Yes, I know that we have a much shiny gold standard right now, but it has to be platinum level in time to come.
Absolutely. I'm keen, Portia, if we have any questions from the room, either on the mic or through Mentimeter. If you'd like to ask any, we're going to just have a little pause and then come on to the second stage of this. But I'm keen, Portia, if there's anything from the room or anyone wants to bring to the table just now.
I'll kick us off while you guys have a think. If you do have a question, just pop your hand up and I can come over. So I've got a question here. Are neuromuscular centres in the UK competing with one another? Do approaches to care differ, i.e. spinal care management, hip management?
Who wants to take that one? Mariacristina.
So there are differences. There are difference of providing treatment or equipment still on a national level. What I can definitely say is that there is no way that we don't communicate between each other. We all communicate. We are aware about initiatives that one center is starting, and we are trying to collaborate to go in the same direction and to have some evidence-based argument that we can bring on the table for NHS, for the community, to say we need to provide this now because we know it's beneficial, because we know it's more cost-effective. Unfortunately, as a clinician, shouldn't be my priority, the cost of something. But unfortunately, again, I didn't come to UK to discuss these things, but the last 10 years of my life and my job were about cost effectiveness. So I know that we all hope for changes, we all hope for improvement, but it's a difficult process. But one thing I can say is that there is no doubt that there is a goodwill to communicate, to collaborate, and as was mentioned several times, Anne-Marie is also looking to what is the current practice, not alone, she's not doing everything in one, just Anne-Marie. I mean, we will all support that as much as we can. But we are trying to look into that. We're trying to have some guidance that are relevant, but not only relevant, possible to be done in UK without having such disparity.
Just before we come back to it, I think it's a really interesting point that the cost side of things as well. I know Giovanni's going to talk about the therapies and side of things, but it's not something that we as a community really consider. Yes, they're expensive therapies and they are game-changing, life-changing, etc. But that cost side of things is something that you as clinicians and centres have to really consider. And I wonder, Channa, just on that little point, if there is something there that it is something that you really need to build that into your way of thinking in terms of making sure that the cost element is actually considered in the overall picture.
It is becoming a real challenge. It's a great question, Giles. Even though we sometimes get the drug free, to deliver the drug and maintain the patients on medications and monitor them, there are significant costs attached to that. For example, we were in the UK, a number of centres were able to have a catapulted start for SMA therapies in adult services because nusinersen was funded. But when risdiplam became available through early access medicine scheme and then managed access agreement thereafter, there was no funding to deliver it. But we were able to somehow other support that service because there was some funding from nusinersen. But there were a number of other centres who only did risdiplam delivery. So for them to find a dedicated physiotherapist who did the outcome measures, contributed to SMA reach, was real challenging. And now there are newer problems in the NHS, particularly in adult centres. There are several drugs on early access to medicine scheme for Duchenne and for myasthenia. And managers are refusing to accept to deliver these services because the drug comes free, but delivering it, pharmacy time, the infusion center time, that is not counted, and we have to arrange our services to deliver that. So we, as clinicians, sometimes we need to also see how managers see and then overcome those challenges, and having discussions with advocacy groups, the industry partners, and to bring community together. How do we design business plans? How do we think to make sure that our trust doesn't lose money by delivering this service will make us access these therapies easy.
There's a lot of learnings as well to take. We're coming into Solgen's MIT, we've got a Pete McGrath around the corner, we've got Spinraza High Dose, we've got Sala Nursing around the corner as well. We understand that it's not just getting the medicine, it is that next step of make sure it's into trusts and being able to give it, and then I'll be able to provide the service that goes with that. Portia, I wonder if we had another question from the room that you'd like to bring to us.
So there's a question here. Someone's had a really good experience with an outreach team, a respiratory outreach team. And they say it helped no end, especially for training schools and things. And they're wondering if is that something that's going to happen more, sending outreach teams into the community to possibly reduce admissions? So outreach teams are few and far between. There's one in Cambridge and one that covers East London. They are like the shiny coin that you just can't quite reach. Funding for them is very difficult, especially from tertiary centres, because our patients are spread so far and wide that you have to be able to, again, it comes back down to supply and cost of a service. You have to be able to get to the patients efficiently. It's something we fought for quite a long time, and we were almost about to do a pilot for 6 months out of Gosh, and then COVID hit, and then nothing happened. And now priorities have changed. The way the NHS is changing and will continue to. So that makes it much harder. I would love nothing more than to be able to go and see my patients in their own home, go and teach in their schools, and do everything that they need us to do. But unfortunately, we are confined by a system. We are looking at ways to do more training and more teaching. But we are limited by what we are given. So in an ideal world, yes, 100% outreach would be amazing. But unfortunately, it's not realistic for most centres, unfortunately.
And before we come back to another question, I'm keen to just know, we've got such a well-connected community. You know, today is a great, example of that. And it's so fantastic to be able to use that voice to be able to change the future and advocate that. What would you say that what the community could do to really help support what the future might look like, whether it be new therapies or continuing to drive our existing support, not just drugs, but the actual support side of things? Is there anything that you would say potentially that our community can do to really help that?
I think it's awareness of the condition, but also what our patients need. Like for anyone who's tried to get a community respiratory physio, it's like a unicorn. Like they don't really exist. So like advocating for more services that can be provided locally, and the training, everything that goes with it, I think would be amazing. Not just respiratory, for other types of physio, for like community nursing teams to know how to look after these patients, but even going back to like health visitors who recognise what SMA is and recognise the disease quicker. And the amount of times we all hear in clinic, well, I said to my health visitor when they came out, I didn't think everything was right, and yet here we are 4 months down the line, and that's when they get their diagnosis. Even going back to there, like education is a massive thing.
100%. We look at newborn screening as a tool, but until that is fully rolled out across the UK, we are still going to have symptomatic people within the community that need to be spotted. And it's something, as a charity, we are just about to launch a new project specifically targeting health visitors, education, awareness, community practitioners, toddler groups, mum groups, etc. So people are starting to actually think, oh, actually, I really spot the signs. Portia, is there any other questions that will come in from the room?
Yeah, there's someone here who has noticed a lack of speech and language therapists at the conference, and they're wondering if you work with speech and language therapists.
It's more for you.
Who wants to take that one, Lisa?
So we have a great network of speech and language therapists who we work incredibly closely with, not just from a clinical point of view, but from a research point of view. And there is loads going on in terms of developments in both sides of SLT. Is there a poster?
I think
There's a
there's a
poster
poster.
somewhere apparently. But no, we have incredibly strong links, and they are a hugely important part of the team that we have.
Another great question here. It says, the onus always seems to be on the person with SMA or their family to find out about any new upcoming trials or treatments. Could this information be communicated better to keep people informed?
I'll take this. I mean, I think that now the information is much better than it was before. And for example, on SMA UK, there are dedicated information about clinical trials, research, upcoming new things. So I think it's much better than before. We probably could do better. I don't know. We probably could have some leaflets to give out in clinic. We could have some information to give out in clinic. I mean, we are very happy to get suggestion from you if you think the communication is not good enough from this point of view. But on the other hand, I just want to remind that clinical trials are a very narrow opportunity. For each trial, for each new treatment, there will be, less than 10 or 5 children in a country that will be recruited for that specific clinical trial. So it is important that there is awareness of what is happening, where is the research going, what could be the next step in terms of drug treatment for SMA, although I totally agree with you, Giles. At the moment, we have these 3 treatments, we should really concentrate on boosting what this treatment can do with a very good standard of care. But yeah, we will be happy to collaborate with SMA UK to find a way to inform better our families of what is happening. In Goshen, in our clinic, SMA clinic, there is always one of the consultants there is also involved in clinical trials and research. So I hope this doesn't come from a GOSH patient. The communication, I hope, is quite open about research and trials. But I can imagine that perhaps this is not across every center. So happy to get suggestion for how we can improve that.
We're very happy to work with you too. And to do it in a way that's understandable, the clinicaltrials.gov website is like a different language. It's very difficult to translate. So yeah, I'm sure working together we can do something on that. I've had a lot of questions on treatment. I'm actually going to leave those till the next session because our next session is on research and treatment. So if you've asked a question on treatment, I haven't forgotten about you. We have a question here about database. I think maybe we need a little bit explanation about what the REACH network is. And I sit on the REACH network committee. And when I started, I was quite intimidated because at that point I was a mum with a little boy with SMA. And I joined this clinical network of very, very impressive, very, very clever doctors. Some of them my son's clinicians, actually. And I was like, are they going to want me here? I feel like I shouldn't belong here. And I was just welcomed with open arms. And I have to say, the SMA REACH network, all these specialist clinicians we are lucky to have across the UK, really, really listen to what I am saying. And I take all, those of you on the WhatsApp groups, as you know, I'm on all of those. And I take all your concerns, I take all your questions to those REACH committee. And they really do listen, and they really do action it. So there's a question here saying, does a national framework of database similar to the CPIP assessment for cerebral palsy exist? If not, would it be of value in the SMA community for collecting information for research, which I think is what SMA REACH is?
I know the database for the cerebral palsy, and it is true. It's a slightly different type of database. But one thing I have to say, so before there were treatments, there was the SmartNet that then became SMA REACH, but there were other networks, in other countries that were collecting natural history data of patients with SMA type 1, type 2, type 3, the PNCRN network in US. Without this database, which is collection of data of patients, when they come for their normal clinical assessment, we don't ask to come more often than that, there would have not been a trajectory of untreated patients against which there would be the first clinical trial in SMA type 1. I want to remind everyone that the first trial with Spinraza was interrupted because after 1 year into the trial, they could see that there was a massive divergence between what was happening to the patient in the trial, the treated group, and the natural history that was published by the PNCRN database, the PNCRN network, which was a database, American network with data of natural history of SMA type 1. And the same happened with SMA type 2, SMA type 3. Without this data collection, without the generosity of patients and families signing before treatment and say, I'm happy for my data to go into this database and to be part of an international effort to describe the natural history of the disease, there wouldn't be clinical trials that would be able to prove effectiveness of these treatments.
Just on that portion before you come in, PROMs, they're so important. You know, we talk about what can the community do as well. Channa, I mean, how important is PROMs?
What's PROMs, Giles?
Patient, you know better than I do. Patient-reported outcome measures. Yeah. How important are those, and how much does that influence and affect continued access, future access, and general service?
I think that's PROMs, or patient-reported outcome measures, I would say is really, really important, because we have various motor function outcomes that we do when the patient comes to the clinic. Sometimes patients might feel as if they're being robotic going through these assessments, hours long, but whether they are capturing what is important to the patient might be a question sometimes the patients have, and they ask us. And therefore, patient-reported outcome measures is really important. Whether the existing patient-reported outcome measures truly capture everything is probably questionable, but I think that is a good start that we have. When it comes to SMA Reach Adult Network, we have come a long way collecting this information to support approval of drugs, and it is true that it is quite daunting when the patients come to the clinic, but they have been so generous to have put up with it and supported us, and our physiotherapy colleagues have continued to collect this. And this data we need to perhaps continue into the future as well, together with the patient-reported outcome measures. Sometimes we do this in the clinics, and often is done through the registry. And I beg and plead the patients to continue to engage and maintain your fantastic engagement thus far, and also they communicate in the clinic. We discuss, and they come and tell us, I have fatigue, you're not capturing fatigue. So we then looked at various scales, and we started doing that in a couple of our clinics in Manchester and Sheffield, and patients come and say that they have problems with palpitations, etc. So Claire Galtry from St. George's and colleagues collected data on things that are important for the patients as well. I think this is an outcome measures are evolving process, and I know Robert is developing outcome measure on swallowing and bulbar function, and these are all important to capture what is important for the patient. So I couldn't stress anymore. Yeah.
Can I just add something important there? You're looking around, but it's me. My perspective for PROMs as a CNS is slightly different, but I think it's important to highlight to everyone here that there's still 2 treatments that have not had a final decision on them because of a lack of data from the patient perspective. So we know through functional assessments if someone's responding well to treatment, but there's many children and young people that I work with without their direct feedback. On paper, it might not look like they're responding to treatment. It might look like they're a non-responder. So PROMs, patient-reported outcome measures, are really, really important to get your voice across. So if treatment's meant that your voice is now louder and you're not on a breathing machine, but we physically as clinicians haven't scored that anywhere because our scales aren't good enough yet, that's why the PROMs are so important. And without data, we can't push change. And the patient voice is one of the most listened to things when, as clinicians, we're trying to invoke a change.
How do we put our PROMs in? How do we submit our patient-reported outcome measures?
Through Newcastle, is it at the moment?
So the PROMs are pushed through the registry to the patients. When I say pushed through, I think they're sent it out. And that's one.
So we get an email. Do we?
Yeah.
Yep.
If I'm saying something different, please, therapy colleagues, please let us know. So in Sheffield, we do it in the clinic as well as encourage them to complete it when the registry sends them the email or communication. I think, is that Does that answer your question?
Yeah.
No, the registry does send. So everyone who's on the REACH network, I remember now, the registry sends them out an email because proms have to be completed within 6 weeks before or after your SMA clinic date. So the proms can go with the clinic information to the REACH network.
Great.
Is the SMA UK registry that send out the emails? It's not SMA REACH that would send this email out.
Okay, we're coming to the end of our session. Portia, is there one more question, or I want to come back to the panel as a couple of final words, but I wonder if there's one more we could take.
I can do one more.
Oh, we've got a roaming mic at the back with Vanessa.
Hi, Dr. Scoto. On what you were saying about evidence on that first question on competing centres, how do you develop the evidence to change things? Because that will ultimately alter the landscape over time. So you say that you'll change things based on the evidence, but without doing things, we don't get the evidence.
The best way to produce evidence would be to have clinical trials, you know, when you have a control group and you have a treated group, and that would go across treatments, meaning drugs, or could be across intervention like orthosis or surgeries, etc. We can't do this at the moment. There is no possibility. But what we can do is collaborate. For example, we are in collaborating to collect data on how we are treating, managing the scoliosis in our group of patients. And this will be for patients who need a spinal brace or those who don't need the spinal brace. We are collecting this data to go together with another center in UK that is currently probably a bit ahead of trialing a new type of braces and things like that. We hope that in this way we will have the famous trajectory that I mentioned before, having something that show in bigger numbers, because only one center will be very difficult to put down some evidence that can be nationally agreed and endorsed. We hope that in this trajectory description, we will be able to have some clinical data that says these patients, these similar patients, treated in different way, they went to different direction. So we definitely are convinced that this treatment is better than the other, that this way is better than the other. And in this way, we can put a stronger voice forward. Sometimes it's, we had times where it was easier for us to access some grants that helped us to do some clinical research. Sometimes it's a little bit more difficult and challenging, and therefore we welcome centers that are able to do that, and we agreed to collaborate in order to put the data together, considering the big group of patients that we have. This is the way we can try to have some UK evidence-based clinical information that we hope we can bring forward, and could go both directions. Could go that the new intervention is really better, or could go the new intervention is not really better. Unfortunately, I don't know any doctor, especially pediatrician, no offense, Channa, who when they start medicine and they start pediatrics, they say, oh, I'm studying this because I want to treat my patient the most cost-effective way. None of us thinks about the cost, to be honest. We all think about what is the best treatment, and it is frustrating for us as well. If there is something that we think is better, we can't access it. It is frustrating for us too. So the network is helping to put data together, to discuss all together. So hopefully, if you joining forces might help to get a more convincing argument in the next future.
We're just coming to the end of our session, and just before we finish, I'd like to just go back to the QR code that I put up on the wall 45 minutes ago. And each of you, it would be really great to just hear your one or two words that you would like to see for the future of SMA. So we'll go down the line. Channa, what were your one or two words?
Even though I'm not a pediatrician, I would love to see newborn screening rolled out for the whole of UK, and we will continue to be able to access new therapies as they develop for SMA without much of a struggle.
Mariacristina?
Newborn screening too, but also collaboration. between clinicians and families and not collaboration.
Lisa?
I mean, I feel like newborn screen is a given, so I'm not going to say that one, but I would hope to see better equity of care throughout the UK.
And Natalie?
Obviously, collaboration and newborn screening and more patient-focused research. I was at SMA Europe whenever the last one was, nearly 2 years ago, and there was a real lack of the patient voice. So I hope to see a lot more of that.
I'd like to just say thank you to our clinicians and our specialists to come on stage today and talk for the last 45 minutes. Like I said earlier, please grab them, chat to them. They're here, make the most of their time. Just finally, a huge round of applause, if possible, to the panel. We now have coffee. Am I right? I'm looking at the slides, so hopefully that's correct. We now have coffee at now until 12 in the main atrium.
We also have, I just want to tell you about, we've got a research bus outside. So if you're really interested in hearing more about research, we've got Adam Brooks Hospital have brought their research bus outside. So do go pop and have a look and talk to them in the break as well. And look at our posters.
Thanks, guys. And we'll see you back at 12.